Welcome on behalf of all of us, both from Medical Advantage and our friends from Wellbox. Thank you for joining us today for our session on remote patient monitoring. I'm very excited about this session for myself and just based on the panel of experts we've been able to assemble. I think remote patient monitoring, especially the area of tech devices, is growing and exploding like crazy. With that comes a lot of noise and confusion and questions. So I'm really looking forward to this session. Our experts, I think, will be able to provide a lot of clarity and great insights. Let me do a couple of housekeeping things. The phone lines are muted currently. We will be pausing a little bit later to take some of your questions. So please use the little chat bubble in your GoToWebinar control panel to submit your questions, and we'll get to as many of them as we can. Okay, let me briefly introduce our speakers. So Brandy Smozeski is clinical manager, a part of the Medical Advantage team. Brandy is a social worker by training and helps us lead and manage any number of the care management initiatives we have with our large physician group clients, ACO clients. Today, Brandy will help to represent the voice of the customer, the provider, the patient, a day in the life, if you will. So thank you, Brandy, for joining us. Elliot Diamond is Vice President of Population Health with our partner company, Wellbox. Elliot brings many years of experience related to healthcare technology from a few different angles, healthcare data analytics, electronic health record or EHR technology, and of course, remote patient monitoring that we'll get into some today. I've heard Elliot speak in the past on this topic, and I think he does a brilliant job of clarifying, just laying out in a very clear, easy to understand way all the noise and confusion around the technology. So welcome, Elliot. And then Jess Ager is the Director of Clinical Services from Wellbox, a registered nurse by training. And Jess is the person at Wellbox ultimately making a difference for the high-risk patients that Wellbox serves. So whether it's chronic care management or for those patients leveraging remote patient monitoring technology, Jess will help us to understand just the real world scenarios where RPM is in use. You know, so often there's so many words, right? It's ACO, it's value-based care, it's portals, it's telehealth, you know, healthcare data analytics and machine learning. At the end of the day, it's about taking care of patients, right? We can't ever lose sight of that. And I'm really excited to have Jess just to take us through how this solution impacts lives. I mean, literally changes lives. So, okay, with that, let me do a quick commercial about Medical Advantage and Wellbox for those who are new. We had done a recent care management webinar together with Wellbox, and I know many of you saw that, so bear with me for a second. Let me just do a quick introduction. Medical Advantage is part of the TDC group. Perhaps some of you are enjoying your professional liability insurance coverage from the doctor's company. Thank you for joining us. So Medical Advantage is a subsidiary company of TDC. We're not in the PL space. We offer a portfolio of consulting services at the point of care to help practices, specialists, physician groups improve performance across clinical, financial, use of practice technology such as the EHR. We have partnered with Wellbox around our care management and remote patient monitoring go-to-market at a high level, and we'll get into more of this as we go. Wellbox is a leading provider in the chronic care management remote patient monitoring area. For those of you with Medicare patient populations, Wellbox makes available a licensed care manager, in effect, to become an addition to your staff with a laser focus on your high-risk patients for regular check-ins, making sure they're staying on track with their care plan, et cetera. We'll hear more about this as we go. So with that, let's get to it. Josh, why don't we take the slides down? Thank you. So Brandy, why don't we start with you? Before we dig into the scenario and all the technology, maybe you can just help us kind of set the context here, if you could think of the physicians you're supporting every day, those providers with high-risk patients, just give us a general sense of what it is they're up against.
Yeah, thanks, Bill. So, the biggest thing that we hear from our physicians across the board, and this has been pretty constant for the last year and a half, maybe 2 to 3 years, it's time. So, we've always had that, we're trying to beat the clock. We don't have enough hours in a day. So, specifically with our physicians, they're blocked within 10 to 20 minutes per patient. 20 minutes is like really kind of expanding it, but for the most part, it's about 10 to 15 minutes per patient, and they're trying to do so much within 10 to 15 minutes and they're not able to address everything. So they have a lot of patients that leave without having all their medical conditions addressed, as well as the physician starts falling behind. So if you spend more than 10 to 15, 20 minutes with a patient, you're behind on the next patient, and it's almost a redundant cycle that it just keeps happening. So you're not able to address everything. The patient's there for a lot longer than what they originally planned to. The physician's with the patients a lot longer. So we hear that. That's probably one of our number one things is going to be the time. And then you're also running into those chronic conditions. So they have those patients that have all of these chronic conditions that they can't address in that time frame, or they just can't address in general because there's so many and you're limited, right? So your physicians in the practice, they're not going into the home. They don't know what's occurring home. They just know what's occurring within that 10 to 15 minutes with the patient. So they run into that. They also run into transportation issues. So especially with COVID and the pandemic occurring, patients don't want to come into the practice. So they're a little bit hesitant to come in. They really need to come in to address what's happening, but they're not coming in. They don't have transportation or they don't feel comfortable coming in because either their medical conditions or what's happening within the world. So we've got a couple different factors happening there. And then if you have a patient that's non-compliant, the physicians are just struggling with how do we address those patients? How do we reach these patients that are non-compliant, not even coming in the first place, whether it's transportation, whether it's concern with what's occurring, we just cannot address what's happening with them. And they're limited on their staff. So that's a big issue we found not only previously to the pandemic and what's occurring, but also, in real time of they have not enough staff to do everything that needs to be done on these patients. So they're just over in general limited on what they can do. And then there's a lot of focus that's going into value-based care nowadays. So you want to focus on being able to provide that high quality care to the patients, but now you're limited on resources, time, staff, and you just can't hit it all. And the patients seem to be getting sicker and sicker or more at high risk for readmissions into the hospitalization or their medical conditions to be exacerbated. So with our physicians, we're just dealing with so many different areas of struggles and obstacles and barriers that they just don't know what to do besides just doing the same thing that they've been doing.
Very good, very good. I mean, that gives us, I think, a great level set, a foundation. Thank you, Brandy. So with that, Elliot, I'd like to turn to you, and maybe you can help us explain how these pieces can start to fit together. One area, maybe just to tee this up, is telehealth, maybe positioning remote patient monitoring versus telehealth. I know last year we saw enormous growth in virtual visits and providers using telehealth technology. Maybe you could start there. Is this just a natural extension to telehealth or something different?
I think it's different. Telehealth is a broad term. When you think of telehealth, it's use of a computer or a phone, video to connect with a patient who's not sitting in front of you, right? The pandemic certainly blew that one up, right? Previously, payers were a little hesitant to pay for telehealth. Everybody felt you needed to go into an office to be seen. That's how healthcare was delivered for the most part. Now, during the pandemic, telehealth increased at something like an 8,000% level. Every provider basically wound up with a platform, was seeing patients virtually, or they were just simply doing it on their iPhone, whatever it was. So it's a great way to see patients. You don't have to physically lay your hand on every patient for everything, but what we do is a little bit different rather. So we all know about chronic care management. Let's start with a regular visit. Patients come in 2-3 times a year, and they usually come in when they are sick. Well, the healthcare system's changed. Now you have to keep people well, right? There are penalties for people being sick. So chronic care management came along. There's a way to connect with a patient, non-face-to-face, every month using our nurses, for example, um, and make sure that that patient is okay. Engage with that patient, find out how they're doing, review their meds, do things like that. That's a great product, right? And we all know about chronic care management. And if a provider is not doing it, they should really consider it because it really moves the needle on quality. But then there's remote patient monitoring. So how is this different? Remote patient monitoring involves equipment. We're actually giving the patient a piece of equipment, whether it's a blood pressure cuff or a pulse oximetry unit or a scale. It could be any of those or other things, and then monitoring that on an almost everyday basis. So imagine patient comes in twice a year when they're sick. Now you put chronic care management in place. You know how they're doing each month. But what about in between? What if a chronic heart failure patient suddenly gains 8 pounds in a 3 or 4 day period? Well, Jess can tell you from her nursing experience, that means there's a problem and someone needs to intervene. If the patient's not being monitored, chances are they don't know that. And chances are no one knows it. So what happens? Patient winds up in the emergency department or worse. Same with diabetes. If you're monitoring diabetics and they have a device and they're being monitored and they're engaged enough to be monitored on a routine basis, well, then you know when they're having issues with their A1Cs, and we can get them back into the practice rather than them winding up in a much worse situation. So that's the difference with this compared to either chronic care management or compared to a regular office visit or a telehealth visit.
Very good. Thanks, Elliot. Now I want to get to Jess in a second just to get into some actual, real world, real patient examples. But before we do that, Elliot, I'd like just to talk a little bit about the technology challenges here. Like I alluded to, it is, we've got so many people rushing into the space. It's healthcare providers, current healthcare technology providers, it's consumer electronics companies. Everyone is converging. So could you talk a little bit about just the
Sure.
Wellbox approach to doing this?
Absolutely. So we're dealing with Medicare age patients. Typically, they're not that tech savvy, right? Now, some of them are, and the younger Medicare patients, 65, 66 years old, they still have an iPhone and they know how to pair a device. But generally, if you look at a Medicare patient, like my mom, right, 89 years old, no smartphone, no computer. So how are we going to monitor data? Well, we believe that you need to make it simple. So as part of our program, we provide the patient, there's no cost to the patient or to the practice. We provide them with whatever device they're going to get. Let's say it's a blood pressure cuff, and it's already paired to a little hub. And that hub is just a little piece of equipment that when it's plugged into any outlet in the house, it automatically starts sending a low frequency cell signal. We want to take technology out of the picture, if you would, because it's a hindrance in many cases. So now patient gets a box, they open it up. Of course, we're there to help if there's any issues, but basically all they do is plug it into the wall and bingo, you've got a low frequency cell signal that every time they use that blood pressure cuff, it transmits the data to our nurses. And our nurses are working with them to get that signal. Can it be done other ways? Certainly. We have an app. We can pair devices and Bluetooth devices. So if a patient has their own Bluetooth scale, we can monitor that. But we find the simpler we make it, the more likely the patient is to use the product, and the more likely we are to have compliance, right? And this is all about engagement. If a patient doesn't want to do this, they're not going to do it. But if they want to be monitored and want to be healthy, we want to make it easy. And that's what we do. Now we can provide scales, glucometers, blood pressure cuffs, whatever the need may be. And we do it just like I said, mail out the two devices, they plug one in and it's paired and away we go.
Okay, great. Thanks, Elliot. So Jess, why don't we talk with you for a minute? Brandy's given us sort of the background of a day in the life of challenges of the provider practice. Elliot's talked a little bit about how it all plugs together, how it works. From your view, from your world, can you just talk through some examples, your perspective on this topic of remote patient monitoring and what it takes to be successful?
Sure, absolutely. And interestingly, listening to both Brady and Elliot, a lot of the roadblocks that they're talking about are identical for the patient. We will hear from the patient that they're trying to get healthy, but they just can't get into the doctor, or they're trying to get, more information on healthy diet, but the doctor doesn't have time to sit with them. So, we're feeling it in every aspect, from the practice providers and the patients. And so specifically with RPM, I love that, you get this snapshot when you go into the doctors, but we have this big picture with RPM, and the nurse is able to really put that data into perspective and get an overall picture of that patient for not only that day, that week, that month, but as time goes on, we're able to see a big trend with the patient. Um, in general, with RPM, it's only effective, like Elliot mentioned, if the patient is engaged. And so because of that, at Wellbox, our nurses are constantly doing outreach to that patient. Whether or not the patient is having an issue or not, that's not the point of our program. We are reaching out to Miss Smith, and we're congratulating her when her vitals have come back and they're all great. What are you doing? Let's talk about this. It's wonderful. You're doing a great job. Or if it's the opposite and they're not quite where they're supposed to be, we're reaching out that same, level of intensity to say, hey, I noticed the last few days you've had some issues. What have you been doing? Let's make a plan. Let's talk this through. So our patients are constantly being spoken to, and they are being coached and congratulated. So it adds to the whole experience that our patients are really, they have a friend almost. Yes, they're a nurse, but they become more than that because they really get to know their patients and the circumstances for all of those different abnormals or normals that they get. So that's a huge part. Our nurses are, we try to consistently maintain the same patient-nurse relationship so that there is that continuity of care, that the patients can feel comfortable. They will laugh. I have so many stories, but one in particular, we were working with a diabetic patient who just, his doctor could not get him under control, just wasn't happening no matter how much coaching. But it got to the point where our nurse was calling uh, pretty much every 3 to 4 days, and he would answer and say, I know you saw that number. I knew you were going to call me. But we were able to really get him down. If I remember correctly, he was like a A1C of 9.1, and he came down below 6 in a matter of months. I mean, he worked really hard, but he did that because he didn't want to answer that telephone and have to tell my nurse, why he was still not following, the actual care plan or treatment plan. And that's another thing, is that we have individualized treatment plans for our patients. So, it's not a generic, well, you have XYZ, so you have to do the following, and that's going to get you to your goal. That's not how we work. We spend the time to get to know the patient. We develop a treatment plan that the patient has so much to do with. We discuss it. Is this going to work? Are you going to actually make this effort with us? We're going to walk alongside you. And I think that really contributes to the overall success of our RPM program.
Yeah, it's really not just, again, easy to get caught up in the gee whiz technology, but it's really about people, nurses, working thoughtfully with patients to change the behavior. I've heard you talk about, forcing the accountability. And also sometimes we providers have situations where maybe patients aren't telling the full truth.
Absolutely.
Right. And,
That's
maybe.
and that's huge, because the provider only knows what the patient reports. But with RPM, they actually have that data behind it and say, well, you may report that everything's great, but on June 2nd, that was not so great. Let's talk about that. And so that engages the patient, that does have the accountability, and they're able to really start taking charge of their own health.
I would say the nurse is more important than the device.
I
Yeah.
would have to agree. The device can only do so much, but you have to get that relationship going. It's got to be the center of everything. Without that relationship, be it from the provider or the nurse, or you're just, you have a box, and a box is never going to do anything. So, but yeah, good question.
Okay, good. We've got a couple questions that are trickling in, but before we get to those, I want to come back for a second and talk about Brandy, you had mentioned the ACO and the cost of care. Elliot, I know this is a topic I've heard you talk about a little bit. So can you give your perspective on this solution as it relates to performing in value-based arrangements?
Sure. So, we all know that medicine has changed and it continues to change rapidly. In the old days, it was all fee for service. You saw a patient, you submitted a bill to the insurance company, and you got your fee, whatever your arrangement was. Not so much anymore. Doctors are charged with reporting quality. They're rewarded when their quality's good. They're penalized when their quality's bad. Risk is becoming more and more prevalent. And one of the things that's tracked is the cost of care, right? It's everybody's concerned about it. It's one of the triple aims of healthcare is to reduce the overall cost of care. Our solutions have shown almost a 6% reduction in the overall cost of care by independent studies. So what happens is, no matter who you are, if you have a patient that is engaged, you're going to have better results. So it doesn't have to be a Wellbox patient. But that's what we do. We engage the patients when the providers don't have the time to do it. This non-face-to-face care, these virtual care solutions like CCM and RPM are a stepping stone to the world of value-based care, where you have to show results. So people that have readmissions from their patients they get penalized. Our patients show lower readmissions. They show lower A1C levels. They show that they're twice as likely to get a pneumonia vaccine, 3 times as likely to get a flu shot. All these things come from what Jess pointed to, this engagement. And I come from the world of engagement when I used to work for another organization, whether it's the patients have to be engaged, but also the providers have to be engaged. The providers that are engaged have more engaged patients, and it's no surprise. So this gives providers who are just too busy to do another thing the ability to have engaged patients and to have better results. And that's, if you're in an ACO, you want what the pot at the end of the rainbow is shared savings, and this can get you there. So I think that providers that are making that transition little by little from fee for service over to value-based care are going to find that virtual care is a great way to make that move.
And they have to close some of those quality gaps too, right, Elliot? So when you're talking about you guys are able to control or measure the blood pressure and the glucose and so forth. So those all assist with closing those quality gaps with those ACOs as well.
That's correct.
Okay, Elliot, Brandy, thank you for that. With that, why don't we segue into some Q&A? We've got a couple questions that have been submitted. Jess, I think this first one is for you, more of in the clinical nature. The question is around, as the data begins to arrive, as transmissions are happening, the patients are set up, the device is in the home, we're starting to receive data. Okay, then what? What's the process? What's the usual workflow?
Sure, that's a great question. So we actually have a few different safeguards within our entire program, but as the data comes into my nurses, it goes into almost like a queue. Each nurse has got a panel of patients. Again, we try to keep the same nurse with the same panel of patients, but there is a alert feature. So whether or not the data that's being transmitted is within normal limits or not, it comes into a queue and it's designated by color. So our nurses can always actively go to those that are designated out of range quickly. And then again, that is something that is set up with the practice directly. You know, what is your comfort? What are your protocols? What would you like us to immediately call you on? Things like that. So that's discussed in workflow so that when it comes in, my nurses know what to do with that information. But once the information comes in and the nurse has gone through and verified the actual data that's being transmitted, then becomes the actual outreach portion. Like I mentioned earlier, you know, we are really good about reaching out to the patient, whether it's a good result or not. We try to maintain at least every 4 days a personalized touch point with that patient. And so that way there's that relationship going on week after week, month after month, and we're able to really spot those trends. So in our work platform, we're able to see where the individual results or vitals come in and they get plotted out so we can really see and spot those trends really quickly. And that allows us to contact the provider and say, you know, whatever the situation, we've noticed that the last 3 days this is going on, you know, call the patient, they state they feel fine, but here's what the data states. So that's in general, that's how it happens, is that information comes in seamlessly. We go through on a daily basis, even if the nurse assigned is not working that day, you know, as a supervisors, we are also able to see those alerts. So we also have our eyes on that number. And that way it helps to ensure that the patient is being taken care of continuously. Whether or not it's their nurse that sees that or not, it may be the supervisor, but we're going to make sure to alert the provider for anything that doesn't really meet the within normal limits criteria.
Great, and then that's sort of a related question then, is the defining the parameters as to, you know, in what circumstance would you be escalating to the provider?
Sure. We review that in great detail during workflow call. We have this standard protocol, you know, everyone's familiar with the standard, what your blood pressure should be, what your blood sugar should be, but that's not always true for each individual practice and or each individual condition. So we do take that time to really get to know the practice, speak with the provider, with his nursing staff, and we get that in written protocol so that we know exactly what to do when these numbers come in. It's not just, well, you know, in nursing school, this was normal. No, we really want to know the practices and we really want to know what they need us to report on and how. You know, sometimes it's just a message, sometimes it's a direct phone call. So everything is spelled out very clearly. And our staff is trained as an extension of the practice. So my nurses have access to the provider's EHR. We're able to go in immediately and put this information into the chart. We're able to contact the provider as if we're sitting in the office right next to them, you know, working. So that makes a huge difference, is that we really are that extension to the practice.
Okay, great. Here's one. What if the patient has their own device? They say they have their own device, whatever it is, and they want to use it. How does that work?
I'll take that one. That's Elliot speaking. So yes, it's fine we have a bring your own device program as long as the device can transmit data, of course. So if you have for example, I have a Bluetooth scale. There's a download that comes with the scale that I use. I'm not reporting this data to anybody, but I can see all my information, my weight plotted over time on my phone. We have an app that we can provide any patient that has the capability to download it. And if they have a Bluetooth compatible device, then we can see that data. So there's no need for us to send them a device. But to be clear, if a patient doesn't have a device, we do provide that device to them at no cost, along with the hub that I mentioned, which will transmit the data back to us.
Okay, great. All right, let's see. Brandy, I think this might be a good one for you. I work at a 4-physician practice. We have considered care managers and remote patient monitoring. We've heard from vendors. I can't get my physicians on board. Any advice?
Yeah, that's definitely one that we hear quite frequently across the board for any new services or anything new occurring within the world of healthcare, right? So this kind of went all the way back to paper charting to electronic charting. There's that resistance that occurred there, and this is kind of the same thing. So we expect it to happen, and with it, that expectation, this isn't brand new. So it's service, but it's an extension of that practice. So it's not a whole separate entity alone by itself. It's an extension with your practice that's helping provide better care, higher quality care to your patients, and helping that practice close some of those gaps or those loops, and assisting with some of those struggles that those practices are dealing with. So the goal of, providing this care management and the remote patient monitoring is really to extend with the practice and increase the overall care being provided to the patient. So with the practices being, a little bit hesitant, completely understandable, the documentation is right in the EMR, so there's no additional work occurring there. It's actually less work for the physician, because instead of trying to identify extra time to work with these patients that have so many multiple conditions, they have this extension to their office. They know these patients are being followed up with once they leave their office, instead of that constant worrying, not enough time to address it. It's there for them.
Okay, very good. Why don't we start to wrap up here? But before we do that, let me just, Josh, if you could put up the next slide just with some contact information. We've got there Elliot and Brandy's contact information. If you'd like to follow up, we'd be happy to talk to you. We do sessions like this all the time. I'm sure we'll be doing future sessions together with Jess and Elliot. We tend to promote these in our social media channels. So please, if you're not already, please like us, follow us in social media. We have a pretty active blog area on our website as well. So with that, let me start by thanking Brandy, Elliot, Jess. Great job today. Thank you very much. To our audience, thank you for joining us. We hope you found this session to be helpful and useful, and we hope to see you at another session again in the future. Please enjoy the rest of your day. Thank you.
Thanks.
Thank you, everybody.
Thank you.